Hello, everyone. Good morning, good afternoon, and good evening from whichever time zone you are joining in from. Thanks for showing up today for the healthcare webinar. I hope you are having a fantastic day. Today, we'll kickstart with an exciting topic, which is improving quality of care through health data analytics. We are really excited to have you all here. Let me begin by introducing myself and AI Core Spot to you. My name is Nitin Naveen. I'm Vice President of Innovation and Strategy at AI Core Spot. With over a couple of decades of experience in different consulting firms dealing with emerging technologies, I feel fortunate to consistently engage with numerous stakeholders, global leaders, and their incredible problem-solving and innovative ideas. Joining me today are a few of my colleagues, Arvind and Naveen, who will add some energy to this event. So a big applause to them for their dedication and hard work to bring this in shape. Now, let me tell you something about our company, AI Core Spot. It was founded over 3 years back and created to serve as a knowledge hub, focusing on emerging technologies, which is AI, ML, robotics, IoT, and much more. Our webinars aim to share the latest technological advancements in the industry. We dive into various tech sectors, unveiling a fresh theme every month and steadily gaining momentum. Our goal as a platform is to become the leading AI-driven community worldwide, where individuals like you with similar interests can contribute to mutual growth and success. We are committed to organizing lots of industry-backed webinars, hybrid events, where we ground our knowledge through credible data from esteemed industry leaders, subject matter experts, thought leaders, and our trusted partners, which is InfoVision and Digit7. Additionally, we fine-tune our content across various digital platforms, which includes podcasts, videos, blogs, and newsletters to shed light on the ever-evolving industry. Now, coming about today's webinar for which you all are here for. As I said in the beginning, a really exciting topic is up for today, which is driving quality care forward with health data insight. So, what we'll cover today? So, our speakers will provide details and deep dive in few points like high-level ideas of data, clinical decision-making, predictive analytics, data privacy, security, and lot many, which is going around in the healthcare industry. Our expert panel will share valuable insights and engage in thought-provoking discussions that you won't want to miss out. Now, let's kick off the discussion with some quick highlights for the day. Meet our community partners for today. We have three great companies, which includes Fresenius Medical Care, InfoVision, and Southeast Health, who played a crucial role in making this webinar a success. Also, a big thanks to all our attendees. Your time and presence means a lot to us. We appreciate your being here to achieve your goals, understand what is going on in the industry, and connect with fellow participants. Our platform's goal is to help you gain valuable insights and build meaningful relationships. If you leave with a few innovative ideas today and build new connections, I'll consider a job well done. Now, let me introduce our speakers for today. Our first speaker is Devesh Dahale, who is Director, Health System Engineering at Southeast Health. Our second speaker is Len Uswiat, who is Head of Clinical Advanced Analytics, Fresenius Medical Care. And our third speaker and moderator for the event is Mark Johnston, who is VP Global Healthcare and Life Sciences Innovation and Strategy at InfoVision. So just one liner disclaimer before we start our discussion. The views shared by all the speakers are their personal ones and is not related to any of the organization they represent for. So now over to you, Mark, to begin this exciting panel discussion.
Well, thank you, Nitin, and thank you to AI Core Spot. Greetings to everyone. Welcome to our webinar on improving quality of care through health data analytics. I'm thrilled to have you all join us as we explore the transformative power of data analytics and driving excellence in healthcare delivery. In today's data-driven era, harnessing the potential of data is crucial for organizations, as we all know, and seeking to enhance patient outcomes, optimize operations, stay ahead of the curve. Data lies at the root of informed decision-making. And in fact, just yesterday, I was attending the 2024 HIMSS Texas Regional, and during that conference, in every session, and it didn't matter what the session was, whether it was successful nursing informatics resourcing justification to leadership in a healthcare system, or the entire foundation of the technologies that underpin healthcare delivery of the future of hospital systems of the future. Data was at the core of making these things a reality. So data sometimes is looked at as data analytics groups within healthcare sometimes look at a cost. It's really an asset. And we're going to go through a lot of discussions today. Throughout the webinar, our session will share their perspectives, real-world examples on leveraging data analytics to enhance clinical decision-making, support value-based care initiatives, enable precision medicine, and drive continuous improvements in healthcare operations. And to begin our discussions today, we're going to at a very foundational question, and that's, what is your definition of data? And with that, let's start with Devish. Devish, if you want to handle what seems like a very simplistic thing that we understand, what is your definition of data? And then we'll let Len have a shot at it.
Good morning, everybody. I've pretty much spent the vast majority of my time and career in some shape or form dealing with data. And I've always sort of wondered, explored what data is and what it means to me. So I'll start with an example and then get to my definition. So think about how much we know about, let's say, nature and the universe, and let's boil it down to how we view time. And we know we've got a year, which comprises of 12 months, and we know that we can break that down from 12 months down to a day, and a day comprising of 24 hours and minutes and seconds and so on. But if you kind of go back in time, perhaps in evolution and in our journey and history of what we know so far, which we can call knowledge, and which had to depend on some level of information. That information had to come from some data that was collected. So somebody took some painstaking efforts and figured out, this whole idea of counting certain number of things and then coming up with constructs of how time can be measured. And therefore now we can rely on that foundation to be able to do all sorts of things. So where am I going with this? So I really define, and I've kind of put a lot of thought into this, I define data as the outcome of the evidence of phenomena obtained from its measurement. So you can pretty much take any phenomena and say, well, can we apply some sort of measurement to it? Can we understand that measurement? And once we know we've understood that measurement, we are now getting closer to recognizing that phenomena as something that happens. And so now, again, back to that example, we can speak confidently about all sorts of measures that rely on time because of the foundational experience we have with the phenomena of time that we measured in the form of our constructs, such as years, days, hours, and minutes. And so that's kind of my definition, outcome of the evidence of phenomena obtained from its measurement.
Thank you for that. Len?
Yes, I think, Mark, obviously it's a foundational and a great question. I mean, I think when I think of data extraordinarily holistically. So I think we're surrounded by data, and I actually think of everything we see around us is a type of data. And I think obviously we all know data can be structured, it can be unstructured, it can be images, it can be text, it can be audio, but it can also be what we traditionally probably thought of data as in, some Excel values that I think somebody sees. So I think of data very holistically, as I said, and when I think of the work that we do in our company, which primarily focuses on treating patients with kidney disease, as you can imagine, that area is extraordinarily heavy on data. And so I do think, to me, data is everything around us, and everything can be turned into data. It can come from a variety of different sources. It can be quantitative, it can be qualitative. But I do think, I think it's really important to think of data very holistically and not to dismiss something as not a source of data, because I do think, again, traditionally people may not have thought of audio waves as, for example, some sort of a data source, but I think that's also very important. So to me, everything around us is data, and I think it kind of obviously echoes what Devesh said as well.
I've taken things from sort of a macro level, so let's take that a little bit further. What are the main high-level ideas of data that everyone in healthcare should know? And assuming that there'll be people watching this that are very involved in data and data analytics, data scientists, architects, but then again, we'll also have people that are not so familiar. So again, what are the main high-level ideas of data that everyone in healthcare should know? Devish, do you want to take a shot at that one? Go ahead.
Yeah. So, I think everybody, for the most part, agrees that data is an important part of pretty much running anything. You could be coordinating and leading a project all the way up to you might be running an organization or a whole country. So to do the work we do, I think we should maybe consciously put some effort into how we understand and would like to utilize data. And I think when it comes to organizations, we probably want to not stay at the philosophical level, but quickly turn to the practical modes of understanding, recognizing, and most importantly, utilizing data. So high-level ideas of data, I think in general, working in the healthcare industry versus other industries, I believe that we are perhaps at somewhat of a disadvantage, which I think healthcare is slowly trying to make up for, and that is infrastructure built with the idea of making sure that we collect data. And then coming from other industries, I can tell you that most other industries have thought about what sort of data will be collected long before any kind of operation successfully produces, processes any component, all the way up to an assembly that can be utilized by a customer. Now, when it comes to healthcare, I think one of the disadvantages is that the source that we depend on for data is primarily our electronic medical record. Unfortunately, the electronic medical record, although it has a tremendous amount of advantages, was primarily has many roots in terms of a platform for documentation and a pathway to getting billed for the services you provide. So over time, of course, the EMRs have developed and we are able to capture more data, but I think we have a long way to go. So where am I going with this? So I think in the healthcare setting, one of the important things that we need to keep in mind is no matter what you're trying to do, aka run an organization, what do you need? It's like driving a car. You need a dashboard. Well, what should be in that dashboard? There should be certain important measures. At what level should those measures be? Those would be the kind of thought processes that you would specifically need to walk through in order to come up with fulfilling that objective. On the other hand, I'll move the spectrum all the way down to, let's say you get assigned a project and you'd like to utilize data. You should utilize data if you're doing any kind of improvement project. So here you would think about main ideas such as what exactly are you trying to improve? Going back to the three basic questions of Institute for Healthcare Improvement, IHI, is what are you trying to accomplish? Once you answer that question, I'm trying to improve blood pressure in kidney transplant patients, for example, right? So then you'd step down to the next level and you'd say, well, how do I know that an improvement, which I'm hoping to make, will result? How do I know that an action or an intervention that I'm trying to implement will result in improvement, right? So that's sort of your second question. And to answer that second question, you would inevitably need to spend time in data. And specifically at a project level, you might want to think about things such as, for the first question that you answered, that is, what do you want to improve? What are the core elements of data you might want to collect? And soon enough, you might get overwhelmed because there might be a lot of data that you might want to collect for even something as simple as blood pressure, besides the obvious, of course, that's measuring the blood pressure. But you might have several other things that you may consider in terms of things you would want to measure. So fundamentally, I think a lot of projects sort of want to take a shortcut and get quickly to interventions for improvement. But I think we need to pause and figure out what sort of data might be the most useful to collect, and generally err on the side of caution, aka collect several different factors that you think might be relevant, but be sure to identify at least one primary measure and a few secondary measures and the elements of data that would actually feed into those measures. So when it comes to selecting a measure, data in terms of what you collect and how you collect it from in healthcare, primarily the electronic medical record and or manual methods as applicable. But you need to sort of spend time in figuring out what that data is, understanding what type of data it is, and making sure that the type of data actually matches with the type of outcome measure that you're trying to influence. And once you know that type of data, you would want to put in systems that would actually help you accomplish that goal of feeding into that first question, and that is, are we actually making an improvement? So those are just sort of generally the steps that I take in projects that I either lead and or coach. And if you think about it, it does happen to be the second foundational block in the well-known Six Sigma methodology, right? If you think of the DMAIC methodology, DMAIC, you first define what you want to do, and the very next thing you do is spend some time in M, which stands for measure. What sort of measure are you going to have, and what sort of data are you going to collect that will make that particular measure meaningful?
I appreciate that, and don't want to deflect from the question because I want to get over to Len and get his thoughts on that. But we do want to touch later on, when it's appropriate, Devesh, on your background, because it's non-traditional, and mine is as well. We both come from automotive, and there's some perspectives there that some people could be wondering, well, how does that relate to healthcare? Why would that be valuable? But I think there's some things you brought up, Six Sigma, which is applicable across all industries. However, your Shannon background and your quality background coming out of automotive and how that's now being utilized in healthcare. We want to touch on that, but you brought up some great points there. We'll get to that, but I think it's key that we delve a little bit deeper into your background and how that's helped you in your current role in healthcare and what that brings. So if we'll get to that, but I'd like to go back over to Len and refocus on some of the main high-level ideas in healthcare. We know about structured, unstructured, semi-structured, and then we can talk a little bit about data quality. Len, if you want to touch on some of the main high-level ideas that everyone in healthcare should be aware of.
Yeah, I would actually say, yeah, I mean, I think Devesh gave such a great answer. I don't know if there's a lot to that. I mean, I will certainly say that because we're kind of surrounded by these oceans of data, I think one of the key things, and I think this is to echo what Devesh said, is I think it's also important to figure out what is important and what is not important. I think at a time when every and any piece of data can in theory be collected, and whatever the number of tremendous amounts of data that's actually generated just purely on the web on a daily basis, I mean, how much of that is actually important? And that, I do think that's a big challenge for most healthcare organizations, is actually understanding of all these petabytes of data that is actually collected, what is important, what is not important, should we be collecting that data, should we not be collecting that data? And I tend to lean on the side of, if you don't know whether the data is useful yet, I think it's probably helpful to make sure that it is somehow collected anyway. I think especially given the fact that hardware and storage space with cloud computing and other platforms like that, I think has become so much less expensive and it's so much easier to collect all this data. I do think it's important to collect it. But I also think over time, I think it's important to understand what are important data elements and what are not. I think I can tell you from my personal experience over time, we had ideas that, I don't know, weather data may be very helpful in understanding which of our patients do not show up for dialysis treatment. But then we realized, well, actually, it doesn't carry that much importance. And so I do think figuring out in these oceans and oceans of data, finding that needle in a haystack, I think is really, really critical. But I would very much lean on the side of collect more rather than less, and at the very least have it available in case it can become useful for some of our analytics activities, predictive modeling activities, and other efforts like this.
Can I ask you, Len, because you brought up a great point there, and I think Devesh should comment on that too, a little bit of insights on how you reach that conclusions and decision making. You're talking about being all inclusive in data and then focusing. How is that within your organization? How do you reach those decisions and who all's involved. If you could shed some light maybe on in your organization how you decide what are we going to focus on and what aren't we going to focus on. How do you reach those decisions within your
Sure.
organization?
Yeah, so I think one thing, and again, just to be very clear, I work for a company that provides dialysis to probably about 35% of the US population, and we operate in in over 40 different countries globally. We primarily focus on dialysis care, so it's for patients whose kidneys no longer function. And I will say we're very fortunate on the data side. I think that back in 1990s, at least in our US organization, somebody had the forevision at the time to say, oh, we should really be storing all this data. And I think in the early 1990s or in the late 1990s, many people wouldn't have thought that. I think, they would have said, oh, great, just store paper charts, medical charts, and that should be sufficient. You don't need to have this data stored somewhere electronically. So I do think somebody clearly had the forevision to say, let's store this data, because if you don't, then I think it will give you a major headache in the future if this information is actually not stored. So I would say that's certainly one important aspect, that we started collecting this data a long time ago. And then the second one, in terms of understanding what's important or not, I think it's in healthcare, and of course it depends what you do, but it's very important to have that connection to the clinicians. What do clinicians think on the ground? I mean, clinicians and nurses certainly generally are not trained in data per se. I mean, they may not be experts in that area. But what I think nurses know is if you sit down with them and if you say, well, what do you think matters in understanding which patients do not show up for their treatment, for example, and they will recite a lot of things off the top of their head. They may not even think of it as a data point, like weather or, somebody's birthday, or there's a big football event or something happening the night before, and then they're going to skip their treatment the following day. They don't think of it as a data point, but it is a data point. And so I think that connection with our clinicians, I think, is very, very critical, because they have experience that goes back hundreds of thousands of years, I mean, in theory, in healthcare. So I think understanding their perspective of what is important is to me, step number one. And then I certainly think, to me, the second step is then, running some of these models. So for example, in some of our no-show predictive modeling, we found that I think weather may make a difference, but it doesn't make as much of a difference as some of the other things that we originally thought should be more predictive of somebody not showing up for treatment, for example. So I do think a lot of this experimentation and, fast fail approach, I think very much is important in understanding what data is actually important and what data is not important. But I think you can only do this if you're actually storing this information somewhere. Obviously, there's many data points that we do not have, that is very hard for us to get access to. But there's some that I think we do have quite a lot of access to that information. So,
Devis, you had a point?
Yeah, I think Len made some really good points, and his comment about weather made me think of one of my experiences back in industry. And when we would follow Six Sigma and Shane, and our goal always was figure out what the root cause is, right? And within this process of figuring out what the root cause is, we often encounter what we call as noise. And so the noise is there to distract you, and noise can come from a lot of different data elements that you might have thought are relevant, but actually might not be. But how do you determine that? And oftentimes when you're working on an improvement project, you don't really know those things. And so you got to give each of these an opportunity to be collected, like what Len was saying, create an infrastructure where such things can be tested, and then determine as to whether these are relevant and do actually make a difference. So in healthcare, what I've realized is that back to that example, I still remember when we would have put extensive amounts of effort into figuring out root cause. And if we didn't find one, we would say, blame it on the humidity. And so, and most times, obviously it had nothing to do with it, but that used to be our joke. But anyway, back to practicality and reality. I think in healthcare, the two important things that people are always thinking of, and those are very difficult to answer, is correlation and causation, right? So you might collect a lot of data, but for sure, I think we should invite a lot of input from team members because you don't want to miss out on something that might be relevant. But then have models such that that investment that you're making in collecting these forms of data, you've given it a fair shot and you've applied, at least to begin with, your correlation lens. And if they stand that test, then that they at least should be considered to be examined further to see if they pass that test of causation, right? So we've heard several different stories of these, sometimes even jokes about correlation and causation. But so that's something to keep in mind. So over time, I've realized that, while other industries, especially those using Six Sigma, have a pretty rigorous methodology when it comes to the M phase, the measure phase, right? You got to use, these statistical tools, sometimes all the way up to, even conduct gauge R&R, types of studies. Well, in most cases in healthcare, while that might be a great thing to do, generally you don't have the time to invest in all of those things because a lot is at stake and many things need to be done, and most times we are behind the eight ball. So what I've kind of done is condensed at least what I've known so far about, sometimes in my previous experience, sometimes our improvement projects would really be focused primarily on just the measurement piece, not on the actual improvement piece. And sometimes that would be important and relevant. So taking all of that, I've kind of come up with what I think would be a decent model for people to use and apply. And I call it the RRAT model. So the first R stands for relevant. So anytime you're, sort of investigating as to whether a piece of data should be considered, then apply how relevant is it type of a lens, and at least you'll have some sense of like, yeah, I think we should collect this information. I think we should figure out whether, day of the week matters with regard to no-shows, right? What Len was referring to. So relevance, I think, is, sort of like that first lens, right? The second R is what I call as reliability, right? So oftentimes we have measurement systems that we say are there, but we've not spent any time on figuring out whether those systems are reliably capturing that data. For example, you might say, I had 0 defects last week. Well, what if you fail to collect that information? Sure enough, you'd get a 0, as opposed to I collected the information and my result is truly 0, right? A blank does not necessarily mean 0. We've learned that in many data collection systems as well. So how reliable is it? Spend some time in figuring out that a reliable system is what you're depending on after applying the relevant lens, right? Next, you apply what I call as the A and the accuracy lens. And again, most people fall in the trap of, spending a lot of time and effort on accuracy, but you're never actually going to ever get accurate data. I've worked in industry where we've used laser micrometers to measure things down to nanomillimeters. And it turns out that very high levels of accuracy were not really required. What was required was a reliable system that gets us measurement in a realm of or a range within which the functional requirements would be met, right? So be careful about accuracy, because sure enough, you can always prove that something is not accurate, much like you can always prove that something is not 100% reliable either. But then apply your accuracy test based upon how accurate do you expect this data to be. Do you want a 95% accuracy? Are you okay with a 90% accuracy? Or is this the piece of data you're collecting so incredibly important that you want to reach that 99% accuracy level, right? So apply accuracy after you have applied the relevancy and the reliability lens. And then lastly, the T, which stands for time. So I think time is really important. Why? Because I have seen so many studies where they literally create 2 buckets of time. Before and after. We've seen several research studies of before and after, right? Those can be misleading because you could pick a time frame within which the overall result for your before was worse than it was for the after, and therefore whatever interventions you have completed are actually, sometimes people will go all the way to saying statistically significant, although they would have to pass certain tests of significance. But anyway, but as a percentage of patients meeting a certain bar, you might say that that's we've made an improvement. Sometimes that could be far from the truth. And so by time, what I'm referring to is that make sure you have collected data over periods of time. That granularity can vary based upon how many data samples you're collecting. So therefore, you might choose a methodology such as having a decent enough sample size to make your measure be plotted over time in terms of by week, by month, and so on, right? So sometimes you might not have the luxury of having enough data points to meet that criteria of weekly or monthly. In that case, you can apply other methodologies such as pick the first 10, 12, or 15, whatever that might be, occurrences, so that you've got a little more sense of confidence in your sample size, right? So no matter what it is, make sure you plot your data over time, because that gives you the tremendous advantage of being able to say, has my system improved from my before versus after? And that is where I think, especially in healthcare, we have a tremendous opportunity to apply an appropriate statistical process control chart, which again, industry has used and validated, and Walter Schuhart came up with it, but it can be applied to anything. And so whatever your measure might be, if you come up with sort of a baseline, which we know is not just one time period, but data points fluctuating around the time period, you've already learned a lot about how your current process works. That in contrast with your after process, showing a reduced baseline with one of the points, one of the criteria for statistical process control having shifted the baseline. If you apply that, now suddenly you have a whole lot more confidence than you would with simply taking two big brackets of time, right? So again, RRAT, relevance, reliability, accuracy, and then making sure that you're plotting that data over time so that your future state is significantly better than the current state, not just visually looking, but actually applying a certain lens, which is generally a lot easier than the typical research methods that are applied in research papers published, but very practical. Again, direct application of what other industries have learned on the shop floor, but applied to your healthcare setting and be able to convince the team that, yes, we have truly made a statistically significant improvement and a reduced or increased, a center line based upon whatever direction you are desiring your data to move in.
I appreciate that. I think there again is a good example of your back coming from automotive and statistical quality control piece and in your background, and everything else comes into healthcare, where there's a different viewpoint and perspective on controlling the quality of the data there too. I want to follow that up though and get specifically into healthcare, where we're dealing with data. Healthcare organizations collect data from and integrate data from diverse sources, as we all know. So how can healthcare organizations ensure that the data they collect and analyze is representative and inclusive and accounting for diverse populations settings? Len, do you can shed maybe some insight and Devish, because I think it's very key to your populations that you serve.
Yeah, I think, Mark, obviously this is such a crucial question, the question of making sure that the data that we're collecting is actually inclusive. And I'm sure many people are familiar with all kinds of examples where that did not necessarily happen. I think we all know that clinical trials tend to focus more on one group of patients as opposed to all kinds of patients. And I think this can result in some drawback. I mean, I think there's examples of where apps were developed to identify if patients have schizophrenia, for example, and they weren't really trained on diverse populations. And so I think folks speaking with different accents, for example, may have somehow triggered the models to come up with wrong conclusions. So I do think being very, very thoughtful about making sure that the data is inclusive, making sure that it does touch on all kinds of populations that we may have, both culturally, from both ethnic backgrounds, socioeconomic status, and a variety of other ways. So I think being very thoughtful about it is really key, because it will lead to bias. And I think, as we all know, most of AI algorithms and data-driven algorithms are based on historic data. So there's bias in the historic data that will translate into bias in whatever the predictions that we try to do in the future. And so I think in terms of strategies and things that we should be thoughtful about in terms of making sure that we collect data on these on diverse population, quite a few things come to mind. So I think the first one is certainly comprehensive data collection. So really making sure that we're collecting social determinants of health, demographic data, health disparity type data. So to me, that's the first item, is really being very thoughtful about the data collection. I think the second one is also being very thoughtful about making sure that it's inclusive, that it addresses patient engagement and culturally sensitive populations, for example. I think in large organizations, data governance, I think, is important. So that's a third topic that certainly comes to mind. How do we better make sure that the data on diverse populations is collected? Well, you got to have data governance organizations that are actually monitoring this type of information for you. For those of us who have published a lot, I think doing various types of analytics and reporting on that data, so doing stratified analyses on data sets, I think is really important. Are you sure that you're collecting, the same amount of patients who, let's say, of a certain ethnicity as what exists in the general population? So I think thinking about this through analytics as reporting is important. I do think community and various other stakeholder engagements and outreach is also critical in thinking about these topics. And overall, I think all of this, to me, it's not something that just happens overnight. I think it's a continuous improvement. And so I think as long as organizations are thoughtful about making sure that the data is inclusive and holistic, and whatever the models or analytics that we're trying to do really do address these different types of populations, I think it's a process of continuous improvement. And as long as we're thoughtful about it, I think everybody should be on the right track in that area. So those are my general thoughts.
Thanks, Len. You bring up some potential sources of bias in healthcare, including selection of the data, measurement bias, algorithmic bias. And to mitigate these, a lot of organizations conduct regular data audits, stratified sampling, rigorous model validation. Devesh, do you have any thoughts on ethical frameworks and governance?
Yeah, absolutely. I think Len touched upon some really important points. To add to what, and I agree with all of those actually, just to add to that, when it comes to bias, what I've seen practically happening is oftentimes, vast majority of our projects are sort of reducing defects, right? And by defects in healthcare, you're typically referring to harm being caused to patients. So before you improve the outcome, first make sure that patients are safe, right? So there's a whole host of hospital-acquired conditions that lend themselves to being improvement projects. So with those things, I think the one thing I've noticed typically is something to watch out for with regard to bias is we start collecting, or we tend to collect, a lot of data on our defects. So for example, those who had a central line infection, those who had a surgical site infection, those who had, you can go on and on, right? So, and then we collect a host of data for those things. And so defect only data is going to tell you only what's happening within those defects, right? Within those who had an infection. But we need to make sure that we balance that out. And before we make a conclusion that this is the primary contributing factor to, you name it, X condition, we need to make sure that we have also collected that data on those who did not have the defect, on those who did not have the surgical site infection, and those who did not have the central line infection, right? So once we apply both those lenses, right, we can now say with a little more confidence that this particular characteristic is truly a contributing or key contributing factor to what we're trying to solve. So that's one thing that I've noticed. Make sure you're collecting data on both sides of your population that that you have visible to you. And the other one I referred to before is, pause a little bit before you declare victory. So you might collect data, we call it the Hawthorne effect, right? You collect data for a couple weeks, you show that improvement. Well, was it sustainable? So apply that sustainability lens. Otherwise, you might be biasing your conclusion toward an improvement that actually was not sustainable, right? So be careful of the Hawthorne effect. And then lastly, when you're using, measures such as risk, be sure to think of changes in a lot of publications rely on relative risk reductions, right? So make sure that you're also specifying the absolute risks. How much did this measure change from 1.7 to 1.3? So that's a 0.4% reduction. And that 0.4% might be significant, but be careful because, relative risk reduction, you might be able to convert that to like a 40% reduction. And that sounds great. Great to say when you're doing a press release, but be careful to also quantify that in terms of how much absolute risk reduction you've accomplished as well. So those would be my three things: defect only, time periods, make sure you've got sustainable improvements before you make a conclusion, and then lastly, relative versus absolute risk. Make sure you're taking, considering both of those things.
Thanks for that. And we want to move quickly into data in its practical use and future use. And how can data be used to influence clinical decision making? Len, do you want to give your perspective on that? And then we'll
Yeah, absolutely. Absolutely, Mark. I just want to reflect really quick, Devesh, again, you said something that kind of started a thought in my mind. I think this whole idea about pausing before declaring victory, I think it's actually a very important point. I think it's very common. Obviously, in healthcare, you do a pilot and you think that, you take 3 months, you evaluate it, you find positive results, you get all excited, and then you roll it out to the whole organization. I do think we need to be very careful, and I completely agree with you, Devesh. I think us as analytics people, of course, we want to see positive results. We want to deliver positive messages, but I do think we need to be very thoughtful about it. And there are methods, actually, statistically, certainly, to deal with this type of situation where you can try to do this type of analysis much more real time and see if these improvements that you may be seeing, are they continuing from day to day, from week to week? And so are we still seeing the same results? So this continuous monitoring, I think, is really important. But to go back, Mark, to your question about how can data be used to influence clinical decision making, obviously, countless examples. I will just bring up a few that we can start with. I think the first one is certainly evidence-based practice, right? So I think using data to drive how we deliver practice. And I think this can translate into clinical guidelines. It can translate to a variety of other best practices. The second one is, I would say, all this precision medicine and personalized care. This can be both incorporating genomic data, but it can also be a variety of all kinds of other data that we may be collecting in our patients. I think data can also be used, as we all know, for predictive analytics. So it's not just to do some sort of real-world evidence generation or doing some other personalized medicine approaches. I do think you can also do clearly predictive analytics, which certainly our team has done quite a lot of this activity as well. You can use data to do population health medicine. I think many of you know this is a big topic for generally healthcare companies, is to have population medicine. Quality improvement, and what we talked about previously, I think trying to use data to continuously improve your quality and to monitor how these different programs and interventions may be working. I would argue that you could use data to improve patient engagement and patient adherence, which is, again, a big topic in healthcare, especially in the world that I live in dialysis care, where I think our patients do end up seeing providers so frequently that adherence becomes really important. Research and development, you could use data to drive your clinical trials. I think we all know this is a whole separate area. And I also would not discount the importance of data in things like driving operational efficiency, driving compliance and reporting. So I think there's obviously quite a lot of use cases, but those are the initial ones that come to mind, to me at least.
Devis, you have some examples?
Yes, this is I think it's a very good question, and actually it even goes to the heart of data, right? So especially when it comes to people who are maybe a little skeptical about the time and investment in data, this goes to the heart of it, which is how in healthcare can data be used to influence clinical decision making. So first of all, I think we need to be humble enough to recognize that what we are going to discover may or may not influence this decision making. And so, but let the data guide us in that direction. So I'm going to give a couple of examples, and hopefully those examples highlight a certain type of methodology that they might fit within, and feel free to see if that works for you in your context. So the first example I'm going to give is actually a project that I've been working on with our team in my current organization on reducing surgical site infections in colon surgery patients, right? So big topic, lots of data, and literally we had this spreadsheet with 20, 25, 30 columns and several rows corresponding to columns corresponding to all the different characteristics that pass through the RRAT lens. And here we are collecting all of this information. So the first category is when you have a certain type of situation where you don't have a lot of frequently occurring instances. Certainly in this case, we should not be having too many of these. So you're going to rely on some sort of analytics to guide perhaps your future decision-making protocol based upon what you've learned. So back to Len's point, certainly you can do a literature search and see what have hospitals been doing to reduce surgical site infections. Well, they're following a bundle. We say, take care of that first, follow the bundle. Well, let's say you follow the bundle and you're still having infections. So now we are wondering, where to go next? So now you're going to rely on your own data to see if you can learn something from it. So in this particular case, really what helped was slicing and dicing the data that we had. Of course, looking at enough data so that we are able to make some meaningful conclusions. But within this realm, as you can imagine, our first slice was actually to see if we have differences in rates, which would be then comparable with appropriate sample sizes that are comparable. And we compared our rates between, three ways by which we typically do these surgeries: open, which is the traditional way, laparotomies, laparoscopic methods, which was sort of the advancement that we had, and several surgeries are done that way. And then the most recent method, which is robotics, right, which is an enhanced version of laparoscopy. So when we looked at our data from these three lenses, we started finding a difference. So then we dug further and said, well, what other lenses using this lens that we've already found to have, to show significant difference, are we seeing differences in anatomical locations? So our next lens was, for example, looking at sigmoid location-related surgical site infections versus others. And we found a difference there. And then finally, out of, again, many different scenarios, we found that patients who had diverticulitis in the sigmoid region, which were done laparoscopically, ended up showing a drastic difference. And now, instead of being at sort of like the 1% versus 2.5% versus 3%, applying these lenses and still using our consistent methodology of percentages, we were able to show that one subsection of population was especially vulnerable to surgical site infections. Where it turns out that laparoscopically doing those put us at a much higher risk than doing it by the other two methods. So we met with the surgeons and we simply just shared our data and we said, this is what we are finding. What do you think? And they shed light upon what the nuances are with regard to these and what their implications might potentially be with regard to what we're seeing, which is deep space types of infections, right? So with that said, what we did is sort of combine their expertise, but this data, and sure enough, they agreed to try to avoid a particular type of approach in this subsection of patients. And we're still monitoring the data, and hopefully we'll, be able to have enough. Like I was saying, the pause is what's happening right now, and we would like to be able to actually, again, show that this is what we found, this is what we did with regard to sharing this data, and these are the decisions we made, right? So it's a pretty significant clinical decision that surgeons have agreed to make, and now we are monitoring data to see if that truly yields us the expected reduction that we were hoping to see. So that whole methodology, I would say, is sort of retrospective analysis, small sample sizes from which you don't get this repetitive type of data to learn from, and so you use that. Second methodology, I think, is where you do get a lot of data on a day-to-day basis. So here you can apply both lenses, right? You can apply sort of that lens where you can say, what have I learned from the data today, and can I make some decisions based on that? And what have I learned, from this data being collected over a long period of time for a given population, and what have I learned from that? So here's where, from my previous organization, I'll kind of highlight two different examples. One was called the Ninja Project, right? So nephrotoxic injury negated by just-in-time action. We really love that acronym. So it was basically to try to prevent acute kidney injury in hospitalized pediatric patients. So for this type of project, think about it, right? So we had a whole methodology. I'm not going to get into the details of this, but it relied upon data at its core, right? So what sort of data is being collected? Well, the data focused around patients who are exposed to a certain criteria referring to a list of medications. So we're using technology here to say, what's our vulnerable population, right? Within that vulnerable population, you have a daily action that's actually happening with regard to when patient rounding is happening. Can we make sure that, again, we're adding a clinical decision-making potential here, which is the pharmacist saying, here are the patients who have met this exposure criteria. We haven't yet made the decision yet, but at least we've raised the awareness to the attending physician who's part of those rounds, right? And then, of course, finally, we in the background are saying, with this process being in place, what sort of changes are we seeing in our exposure patterns? And then more importantly, if we influence our exposure patterns, along with, of course, other activities such as, initiating that serum creatinine, if that particular situation happens. And then, of course, if we do that reliably, are we able to get a handle on how our acute kidney injury rate is changing? Because that's really our end goal, right? So once you create this set of measures, they actually work really well together for you to now move to the population level and say, for our hospitalized patients in this hospital, how have we impacted their acute kidney injury rates, especially those that we may have potentially induced through nephrotoxic medications, right? So that's an example of how you can apply this, kind of at a daily level, as well as extrapolate this to a population level. And then a similar such thing can be done in the outpatient setting, which is my third example. And so in the outpatient setting, things are going to be a little different. So you're not going to have the typical rounding, but it's a different environment. So in this case, again, from my previous organization, we essentially used our CKD population. And we said, hey, can we come up with something that will help us make better informed clinical decisions while taking the patient's inputs as well as the clinician's holistic view of that patient? So previous scenario, patient comes in, doctor does a little bit of research on that patient. You got your 25 minutes to figure out a lot of things, and then patient leaves, and hopefully everyone feels that all the right things have happened. Well, you introduce something called as PVP, we used to call it, pre-visit planning, right? So for the pre-visit planning process, what we did is essentially collected a lot of data prior to that visit happening and introduced a multidisciplinary team setting so that long before, typically a week before, the patients are supposed to be visiting, we have already reviewed, the clinical team, the multidisciplinary team has reviewed this information, which has relied on collecting these pieces of information. And we created basically a methodology, right? So we love acronyms. So we had created something called as grab a buck, and each of those letters meant for certain parameters that we collected for their kidney health. And knowing those things and having a plan in place now enabled that clinic visit to be so much more productive and insightful with regard to what was accomplished during that meeting. So it didn't happen by magic. It required a infrastructure to be put in place. It required commitment of the people to follow that particular process, which is the pre-visit planning process. And doing that prior to that clinic visit really resulted in, again, extrapolating this to the entire population. We were able to create an outcome measure that was comprised of each of these elements, and we were able to actually say that we have impacted the entire population by using a methodology which is not just individual patient focused, but also resulting in our confidence in actually improving, and in this case, slowing down progression for these CKD patients. So there you go. Depending on the setting, you might want to tailor your approach to saying, how are you collecting the data? How is it being used real time? And how are you extrapolating it to know that all this effort that you have spent in creating a system is actually improving your overall, and this measure again would be at a much higher level, and this will give you the confidence to be able to say that you have truly impacted that whole population.
Thanks for that examples as well. We really wanted to focus in on predictive analytics. It's a key topic, obviously, today, and machine learning models supporting diagnosis, treatment selection, risk stratification, enabling more personalized and informed care decisions. Len, do you want to give some insights? I know it's key to both of you as well, but Len, if you can give us some of your insights there.
Yeah, no, sure, Mark. I mean, I think so. I would say we've actually started this journey with predictive analytics, machine learning, data science, probably back in early 2010s. I think it's been quite a long journey for us. And at this stage, we have actually a suite of probably over 30 different predictive algorithms. Majority of these algorithms are very clinical in nature, while there are some examples, of course, also that are not clinical. For example, predicting when a given patient may leave our clinic, for example, and go to another clinic. I mean, that's another type of example of something that is not necessarily clinical, but certainly of interest from an operational standpoint to our clinicians. So I think our team, I want to stress the fact that the work we've been doing in this area is global. So since we operate in a global environment and we have clinics in over 40 different countries, we also build these algorithms that are in different countries. And these predictive algorithms are very country and region specific. I think we should always remember that while biology is the same globally, some of the practice patterns and regulations and reimbursement and all this other stuff, that is very country specific. And so for that reason, I also think predictive algorithms should be very much country specific, depending on what the need is in a given region. The example I often use is, for example, unexcused no-shows. It's pretty common in the US for people not to show up for treatment, whereas I think in many other parts of the world, that's pretty much unheard of. If you have an appointment with the doctor, you will come and see that doctor. It's very unlikely you have it. So this suite of about 30 different algorithms that we've developed, there's various ways of categorizing them. But instead of categorizing them, I'd rather just give you some specific examples that hopefully folks can relate to. And so I think one big area, certainly for us, is anything having to do with understanding when our patients go to the hospital. Our patients go to the hospital on average 1.5 times a year, at least in the US. That's like huge per patient. So on average, a patient will go to the hospital 1 to 2 times a year. Again, huge number. And so trying to avoid that is really critical. And we all know there's some avoidable, some unavoidable hospitalizations. And so that's one big area that we've been doing since, again, early 2010s. And we've seen some very positive results in being able to reduce some of these hospitalizations, or relatively positive results. We've done a lot of work in medication management. It's a big topic, again, for a dialysis organization, is try to understand how to optimize medication management. An average dialysis patient takes 12 pills a day. How do we make sure that what is the ideal dose of a medication for a given patient? Obviously, ultimately, it's up to the physician, but can we provide some recommendations based on some neural networks and other algorithms? So we've done a lot of work in, ESA administration, bone mineral metabolism drugs, iron medications, and things like this. We've done a lot of work in the area of no-shows, as an example, trying to make sure that patients do show up for treatment. And if we think a patient is not going to show up for treatment, then we try to predict that before that happens, because it's very detrimental for our patients when they actually miss even one dialysis treatment a year. There's been a big focus, and I think it's been going on for a number of years now, in trying to move more of our patients to home therapies as opposed to doing it in the clinic. And so there's a suite of at least 5 different algorithms that have been developed. And the very last thing that I'll mention, although again, there's many other algorithms, is anything having to do with access. Access to a blood supply is really key in dialysis patients, and there's a lot of possible problems that may happen, infections and thromboses and a variety of other things. And so trying to estimate when will these events happen before they actually happen and before it's too late. So we've done a lot of work in using structured and unstructured data, images and text and even sound that your access may be making. I think trying to use that in being able to do these predictions. So we've done quite a bit of work in that area, and certainly something that's really key in driving both improved performance, improved clinician and patient satisfaction, and also, of course, improved financial performance in some areas.
And if I could follow that up too with you, Len, how do you measure and quantify the impact of those analytical techniques on quality of care or financial performance metrics? Do you?
Yes. Yep, Mark, great question. And actually, I think this is one of the areas that I think maybe quite a lot of folks don't necessarily focus on, and especially because AI and data science, all of it is such a hyped up topic, understandably. But I think a lot of folks are developing models that are just fun to develop. They sound fun, they sound interesting. Let's do a face recognition. Let's do, I don't know, emotion analysis of a patient's face. To me, the question is, what is it that you're trying to do, and what are you going to do with this information? And so for that reason, when we develop our predictive algorithms and when our data scientists create these algorithms, we immediately focus on what will be the intervention. What are you actually going to do with this piece of information if you have that prediction, number one? And then number two is measuring those outcomes. And so when we talk about measuring outcomes, we have actually developed a fairly sophisticated process. We don't always follow it, but we try to follow it. We call it our drug development process or AI development process. So we usually start with these phases, very similar to when you develop drug, phase 1, phase 2, phase 3. And phase 1 is usually not about, oh, does this make a difference on patient outcomes? Phase 1 is usually more about how are clinicians actually going to use this particular model? Is the model predicting what we expect it to predict? So those are the types of things we usually focus on. And in terms of the actual outcomes, so yes, we focus on 3 different things. Those are the most important things to us. So number one, we want to focus on improving patient outcomes for our patients. And so some models purely just improve patient outcomes. That's one area. The second area is, does this approach or model improve financial performance? And third is, does it improve patient or employee satisfaction? And to me, whatever we do has to hit one of those areas or all of those areas. So that's kind of how we usually think of it. And we're very, very organized, in my mind, I think, relatively speaking, in that approach when we do this. So.
Thanks for that. And we're limited on time. And I really quickly wanted to get in a question. And Devish, I'll aim it to you. Can you share some insights on how you're utilizing data analytics to support value-based care initiative, such as population health, care coordination, and cost optimization at Southeast?
Sure. I think you mentioned a lot of things, and value-based care by itself could be a topic that you could discuss for an hour. So I'll try to condense that into how we are applying this in an acute care setting, and that by no means is a comprehensive approach for an entire community, but does apply certain principles that you could use and extrapolate as well. So one of the things that we do is we identify from the suite of, I think it's in the thousands, CMS measures that have already been defined. So we don't need to reinvent the wheel. We just need to study what is available. Well, that still leaves us with a lot of measures. And when it comes to applying it to an organization and aligning the organization with regard to what should we be working on long before what all data to collect to support those initiatives, we have essentially a team of our chief medical officer, our quality director, and myself, and we spend a lot of time doing what we call as pre-work. And we do a lot of data analytics within each of these measures. And we use a tool called Midas, which actually interfaces very nicely with the EMR system that you use. In our case, we use Epic. So Epic has some advantages, but Midas, what it does is it actually takes these CMS definitions and then literally gives you your organization's performance as well as some benchmarks to compare with. So once we do that, we have now effectively utilized our data analytics to boil down where our biggest opportunities are. And then we apply sort of, the Institute of Medicine's lens of saying safety, efficiency, timeliness, effectiveness, patient-centeredness, etc. And we say that, hey, out of these measures that we have picked, one, we need to make sure that these do have truly opportunity for improvement, rather than ones that we already are doing well in. And then is it balanced, or are 9 out of our 10 measures all in safety and only 1 in timeliness of care? So that's kind of our process for being able to select these. And then once these are selected, they basically make it to the core or key initiatives that the organization is committed to be working on. And that actually goes on the organization's scorecard, based upon which we evaluate ourselves. The whole organization evaluates itself and says, how well have we done with the few things that we have decided to focus on? And did we truly meet our improved level? And we have 3 different levels, sort of like the green, which is just meeting the national benchmark. And then we have a blue and a gold, which says that we've met the 25th percentile and the top 10 percentile. So, or the 90th percentile rather, and the 75th percentile, I misspoke. So that's a way by which, you can apply, for example, a methodology to say where in this, sea of data, even within CMS measures, what do you do with it? But condense it down to a few that you can work on and show that improvement. And in the following year, before you are ready to retire a measure, make sure that you have achieved, back to that previous discussion, a sustainable level of improvement, and then move on to additional measures.
Thank you for that. Arvind, we want to conclude and thank our panel members here and turn it over and thank you, AI CoreSpot. We've got an important question, I think, centers around which we wanted to get to. There's so much to get to. A federated or a centralized model in data within organizations. I think it's critical because it seems to be disparate. Seems to be a lack of maybe clear ownership in that area. It's a kind of a lengthy question to answer. We want to answer that. We'll answer that offline. I want to thank our panel members today. I want to thank AI CoreSpot. Thank you very much for inviting us this informative webinar. Data is key. You can see there's so much to talk to, even though we have a lot of time here. We barely got through 10 of the key things we wanted to address today. With that, I'll turn it over to Nitin and Arvind.
Thank you, Mark. Thank you, Len. Thank you, Devesh, for your exciting thoughts on this healthcare data analytics topic. We would like to express our appreciation to all our community partners who have been with us till today, all our distinguished speakers who have been speaking throughout on all our panel discussions, and all the attendees who have registered with us from the last many years. And I'm sure they understand a lot of things from this forum and created a space for knowledge enrichment. As our panel members were outstanding, we value the willingness to collaborate and share the valuable insights. In case anybody missed any part of the session and want to revisit it, today's event will be available on our company's YouTube page for your convenience. As exciting technological advancements are on the horizon, we are thrilled to explore more in the coming this year. Looking ahead, we have a diverse lineup this year focusing on sectors such as banking, financial, insurance, telecom, retail, healthcare, supply chain, manufacturing, and much more. So stay connected with us for the continuous learning. For more technological updates, visit our website and social media channels. We'll be sharing a wealth of knowledge, including details, announcement for upcoming events, and much more, aiding you to in registration. We look forward to your support. Please like and share our content on the social media. A heartfelt thanks to our InfoVision, who is our knowledge and innovation partner, and Digit7, who is our technology partner. Explore their website at infovision.com to delve deeper into technological advancements. We as a company, AI Core Spot, thoroughly enjoyed bringing this session to you and hope you found it as enjoyable as we did. We eagerly anticipate more sessions with you in the near future. Till that, take care and have a great day and year ahead. Thank you.
Thank you.